talk to you a little bit about cardiovascular MR. It's almost impossible to do that in 20 minutes, so I'm really just going to cover the basics rather than going into some of the advanced techniques that we have available, because actually it's the basics that we use every day clinically, and many of the advanced techniques are still sort of research and interest applications, I guess, for those hardcore people who are practicing in the specialty. So hopefully you probably know all of this, is that one of the great advantages of cardiac MR is it's extremely versatile. We can assess anatomy, morphology, function, perfusion, flow, strain, torsion. We can characterize the tissue to see whether there's edema, whether there's infiltration. We can decide whether the myocardium is dead or alive. We can look at the coronaries. So all of that versatility is what we talk about when we talk about multi-parametric imaging. And so if you like, in some ways, you could say we could combine all of the different techniques from CT, nuclear, echo into one scan. Controversial perhaps, but what you see is that really there isn't a cardiovascular disease area now in terms of pathology that you, in some cases, that you couldn't argue that an MR can be helpful to guide clinical management. Now, I'm not saying that we should be doing MR in everybody, because that's completely bonkers, but there are difficult cases, particularly when surgical decisions are being made, when all of these different cardiovascular disease conditions that you can see listed there, MR could be useful in that decision-making process. What are the advantages of MR? Again, you'll know this, it's not particularly exciting. It's a safe modality, there's no ionizing radiation, it's non-invasive, very large field of view like CT, so we get full cross-sectional imaging, multiplanar orientation, so we can plan that imaging plane in any of the 3 dimensions that we like. We've got fantastic tissue contrast between blood, myocardium, and the surrounding tissues such as fat. You've seen it's multi-parametric. It is highly accurate and reproducible, and as such, it's the reference standard technique for many of the parameters that we want to measure, whether that's left ventricular volumes, right ventricular volumes, atrium, whatever. It is so reproducible that it has become the sort of industry standard, if you like, particularly in around clinical trials where reproducibility is so important. What are the disadvantages? Well, I've actually sort of updated this slide and coded many of the disadvantages which I've had listed for the last sort of 10 or 15 years. I've sort of moved them to green, really, because we've sort of worked through a lot of this. Obviously, it is a little bit claustrophobic. It's got less so because the scanner bore has got bigger in all of the modern machines now. We're not really limited by patient habitus very much now. I mean, the table will take, I think, 180 kilos. 70 centimetre bore will take most patients, maybe not some of the really large ones. AF isn't a problem for us anymore with arrhythmia ejection. I think we've got reasonable numbers of trained staff. We don't have a shortage of magnets really anymore, because any magnet that you buy is cardiac enabled. All you have to do is buy a coil and make sure you've got the software on it, so it's not a magnet issue. And this issue around devices is really, really interesting, because that's evolved dramatically in the last few years. Every device that we implant in our hospital, whether it's a bradypacing system or an ICD, is MR compatible. And the issue has been about the older legacy devices. There are now lots of studies of thousands and thousands of patients to show that it is safe under certain conditions to scan most of those legacy devices. And in fact, the manufacturers are backward recognizing that their devices increasingly are MR conditional and so safe to scan. So we do scan non-MR compatible devices. There are tiny handfuls of ones that we don't particularly want to do, particularly if the clinical indication is soft, and we would choose other modalities. I think one of the things that people have always talked about is MR just feels a bit long and complicated, it's hard to do, but that is evolving really rapidly now. We're just publishing a study to show that we can do ischemia function and viability in 17 minutes. So that makes it potentially the fastest ischemia assessment test out of any of the modalities. Is it expensive? Well, again, there's a lot of debate around that. There's a lot of health economic analysis studies now, particularly in coronary artery disease, to show it is actually cost effective because of its superior diagnostic accuracy and reduction in downstream testing. So lots of these things, as I say, have evolved. Now, there was a useful paper, you might want to look at this, it's a little bit old now, looked at all the different European guidelines and where MR fitted into all the guideline recommendations. 26 guidelines, 40 of them had high-ranking explicit recommendations for use of CMR. There were 3 that CMR wasn't even mentioned in the document at all. These were some of the older guidelines, and perhaps you wouldn't really expect CMR to be useful in the management of dyslipidemia or perhaps atrial fibrillation. So it's not perhaps surprising that it hasn't got into those guidelines. The most useful, I guess, guideline, or the guidelines that cite the use of MR the most is in coronary disease, aortic disease, hypertrophic cardiomyopathy, and revascularization decisions. And again, that's perhaps not particularly surprising. Now, we talked earlier on this week about stable coronary artery disease investigation. As I've said to you, the European guidelines that have just come out in 2019 are actually very sensible, very pragmatic. They don't differentiate between the different modalities in terms of their use for the diagnosis of stable coronary disease. They all get a class 1 indication. They talk about the using of the tests according to clinical likelihood and what's available and your local expertise. And this just shows you one of the figures from the guidelines to show that basically, like what I showed you earlier on in the week is if you've got a lower likelihood and you want a test that really rules out obstructive disease, then CT is brilliant. If you've got a really high likelihood and you've got a 70-year-old smoking male diabetic who's got classic angina, you don't really necessarily need to know that he's got atheroma because it's quite obvious. You just need to know perhaps has he got something that needs revascularization. So you might want to go more towards a functional test in those higher risks. But you can see the sort of the use of the different modalities, whether it's against invasive coronary angiography or FFR, and you can see that CT is widely useful, particularly at the lower ends of the rule-out test. Functional imaging is very good, often more at the roll-in side of things, i.e. demonstrating that ischemia is present. Why is MR so good? And I've told you a little bit about it before. It's not a one-trick pony, so in a single scan, and I said to you, even in 17 minutes, we can potentially do this if we don't do that bit, because that takes ages. But function, ischemia, viability, 20-minute scan, and it gives you all the information as a single test. And we know this is good. This is the CMARC study that I was involved with years ago, and this sort of set the benchmark really for cardiac MR and how it moved into the clinical guidelines and got its class 1 recommendations. This is the largest real-world prospective study of CMR, 750 patients, all who were required to have X-ray angiography, irrespective of whether the MR was negative or positive. They all had nuclear perfusion imaging, and again, whether that was negative or positive, they all went on to have an X-ray angiogram. That's really important because it's only by cathing the negative studies that you can work out what the false negative rate of a test is, and it's only by doing that you can derive its sensitivity. So some people have said, slightly tongue-in-cheek, that maybe CMARC was the best nuclear study that's ever been performed because it actually identified its true sensitivity for the first time. But essentially what it showed is it doesn't matter whether you've got stenosis at 70% as the threshold, 50%, whether you're looking at single vessel or multi-vessel disease, MR outperformed nuclear in terms of its area under the curve, the blue lines versus the red lines, and the same in males and in females. So it was a very, very good diagnostic test. Now, I've talked about the coronaries. We can produce very nice coronary images, but we don't then tend to do it very often because there really isn't any point when you've got fantastic cardiac CT. Why would you spend 10, 12 minutes trying to produce images like that when you can do it in a single heartbeat acquisition with low dose nowadays? There are occasions when we want to do it though, and it is actually very good for aberrant coronaries, particularly if you're thinking in children, young adults, where you don't necessarily want to irradiate them. And it can also be useful in the sort of pediatric population with Kawasaki's disease, where you're doing long-term follow-up of aneurysms, because again, you might not want to do frequent annual or biannual CT scans, potentially, depending on what scanner you have in your hospital. Myocardial revascularization decisions. Now, I sort of alluded to this the other day. If you look at all of the indications for why we might want to do PCI or CABG, these are the ones that get the class 1 indications, okay? And if you look at the little caveats to every single one of those, there is a reference to what's going on down here. And there isn't a single indication for revascularization that isn't in the presence of ischemia, whether you detect that non-invasively or invasively by FFR. So you shouldn't be revascularizing anyone in absence of ischemia. And that's really important because we have some very good ischemia tests. And as you saw in the European guidelines, the other European guidelines for the investigation of stable chest pain, ischemia testing is very helpful, particularly when you think it's of high clinical likelihood. Why is MR so good? Well, one of the things that makes it really good is the spatial resolution. These are some perfusion images we did a few years ago now, but this is in-plane spatial resolution down to about 1.1 millimeters. Okay, so we can resolve very tiny things, subendocardial ischemia. Compare that to MPS SPECT, where the spatial resolution is around 8 to 10 millimeters. So probably in SPECT only 1 or 2 pixels across the myocardium. We can see tiny little areas. So it's really good at picking up multivessel disease, which we know is prognostically important. Here's a study that was published just in the New England Journal of Medicine last year. This is basically a global multi-center trial of patients with high clinical risk of coronary disease randomized to either having an angiogram plus or minus FFR to guide their treatment or the single test of CMR. And essentially what it showed was there was absolutely no difference in outcomes in these 918 patients over the first 12 months in terms of death MI or target lesion revascularization. But what it did interestingly show is that if you use CMR to guide revascularization rather than an invasive strategy, you actually did a little bit less angiograms, or you obviously did less angiograms, but you did less revascularization as well. And there was no penalty for doing less revascularization in terms of clinical outcomes. So again, perhaps a non-invasive strategy is better even than what we consider to be the gold standard of an FFR evaluation. Let's turn to the heart failure guidelines. Again, you can see here, echo is the sort of workhorse, but you could consider perhaps MR if imaging subjects have got poor acoustic windows or you're worried about complex congenital heart disease. Late gadolinium enhancement imaging is potentially useful to distinguish between ischemic and non-ischemic DCM phenotypes. And I think if patients have got possible myocarditis, amyloid, sarcoid, Fabry's disease, the sort of common things that we see, hemochromatosis, non-compaction, it gets a class 1 indication. And again, useful, as with the other functional imaging tests, for guiding complex revascularization decisions in patients with heart failure, potentially ischemic symptoms and viable myocardium. This will just give you a nice example. Here's a patient that I was involved with scanning years ago now, but it's just such a nice example. I've had it on the slide deck for a long time. So 80-year-old lady, heart failure, 3-vessel disease, ventricle looks really quite poor. You can see the late gadolinium enhancement imaging. It's pretty much black everywhere. There's some little subendocardial bits of white indicating scar, but generally all 3 territories are viable. Now, I guess there's not that many 80-year-olds that would get a bypass in some hospitals, but this lady got a bypass on the basis of 3-vessel disease, heart failure and viable myocardium, and there you go, 6 months later, her ejection fraction is 60% and the heart looks fantastic. So it can be very useful to guide these decisions, but there aren't any clinical trials that show us that this is the right approach to do, surprisingly, for any of the modalities. What about in STEMI? Now, you might say, gosh, there's hundreds of these, and there are hundreds of them. In our hospital, we do about 1,100 primaries a year. And we wouldn't want to be doing MRI on every single one of those because that would be bonkers, and we'd need to buy another magnet, I think, to do that, and we already have 3. But there are times when you might want to think about it, when the echo images are poor, for example, when you might have multivessel disease. But I think this is the really interesting thing. This has come out of the new European STEMI guidelines, is this concept of MINOCA, so myocardial infarction, non-obstructive coronary arteries. Reported series suggests that this is around about 15% of cases. And the difficulty is to know what is the underlying problem here in these patients. They're often younger. They may have myocarditis, but they could be incorrectly labeled as an acute coronary syndrome. They would end up on lifelong secondary prevention inappropriately. They may have a missed infarct because either the interventionist has missed a small branch that's occluded and you just didn't spot it on the angiogram, or it's been spontaneous reperfusion. But the MRI would tell you very clearly that there's evidence of infarct, so that would be a very helpful test to say, well, actually the angiogram's fine. It's not fine, they've had an infarct and we can see it. Or they may have Takotsubo, hypertrophic cardiomyopathy, or other cardiomyopathic presentations. And obviously MR and echo fit into the algorithm for this MINOCA process in time to work out what the underlying etiology is. MR is very good at phenotyping the infarct. These are just some extreme examples, but you can see here, late gadolinium enhancement image, and the whole of the anterior wall is white, it's dead, it's thin, it's not contracting, whereas this infarct is tiny in the anterior walls, a little bit of subendocardial infarction, perhaps a very subtle wall motion abnormality. Sometimes the wall motion abnormality, particularly in the non-acute phase, is not possible to resolve at all, and it just looks completely normal LV function, but you've still got an infarct. But other things we can do, we can look for acute edema, area at risk. We can see intramyocardial hemorrhage. We know that has independent adverse prognostic value in putting patients at high risk if they've got intramyocardial hemorrhage. Same with microvascular obstruction. We can see that in the core of the infarct. So the white infarct with the black core in the middle, that's a bad thing to see if a patient has got that. And LV thrombus, again, a very important thing to be able to detect. Now, here's a case, 60-year-old, 64-year-old man, previous MI, shortness of breath. What's the diagnosis? The guy's going to tell me the diagnosis is a really poor echo that we've done. And yeah, it's probably echo from a few years ago. It doesn't like any of the Bart's echoes that the guy showed. So maybe I'm being a little bit disingenuous, but what's the diagnosis? Anyone shout out? It's not easy. Look. Yeah, apical aneurysm, it's dyskinetic, it's bulging outwards here, isn't it? Okay, so the diagnosis is massive apical LV thrombus. So what you were seeing there was the thrombus, you weren't seeing the apex at all, and that can be quite tricky to image the apex sometimes, particularly if it's very aneurysmal. So here you can see that's the same patient, the MRI scan, a little bit of contrast, the thrombus is black, the infarct is white around the myocardium with this darker thrombus in the middle. And here's a really nice meta-analysis published recently to show anterior STEMIs. LV thrombus was, where is it? I think it was about 12% of anterior STEMIs. If the ejection fraction was below 50%, it went up to about 19%. So actually, it's more common than we think. And the reason we know this now is because we're doing a lot of STEMI trials using MRI as the primary endpoint, whether it's drugs and devices, and we're just seeing loads of LV thrombus now. Clinically, what does it mean? Well, we don't really know, but we are seeing lots of LV thrombus and we are treating it. And we know that echo does struggle, particularly with the small thrombus right down at the apex. And so compared to MRI, it was saying it was about a 30% sensitivity for detecting these small thrombus. Now, as I said, clinically, what do these little tiny thrombi mean? We're not entirely sure, but we still anticoagulate them. What about hypertrophic cardiomyopathy? Again, high-level recommendations from the ESC guidelines, particularly for patients with HCM, okay, to look for the presence and extent of myocardial fibrosis. So there's a lot of interest around this concept at the moment, whether it has independent prognosticability compared to just LV wall thickness and other HCM clinical parameters. Also high-level recommendations in patients with apical disease, suspected amyloid, sarcoid, things like that. We're going to hear a lot more about HCM in the next few years because the global HCMR trial has now finished recruiting 2,000 patients. They're going to be whole genome sequenced. They've had extensive imaging phenotyping from MR, echo, plus loads of other things. And what we'll be able to see from these 2,000 patients is whether MR variables are independent of all the other clinical risk factors that we currently have in our risk algorithms for HCM. So I think watch this space, and I wouldn't be surprised on the basis of that whether this becomes a 1A recommendation in the future. So here's a standard patient, 44 years old, no symptoms, dodgy looking ECG, difficult windows on the echo, possibly normal echo, had a CMR. I guess you probably on today's echo you might not have missed that, but on echo a few years ago it would have been challenged. But look at this massive septal hypertrophy, impaired intramyocardial contraction seen on those TAG cine images. You just see the diagnosis very quickly because of the tissue contrast in relation to the blood pool and things like that. So it's very easy to pick up and spot. And here's what I was talking about, late gadolinium enhancement. These are sort of diffuse, patchy mid-wall areas of fibrosis, often in the hypertrophied segments, but not always, can be in the non-hypertrophied segments as well. You see it a little bit here on the four-chamber, a little bit of mid-wall fibrosis. And there are a number of studies now, this is just one that show, but it does seem to have independent risk prediction if you've got both fibrosis present and the extent of fibrosis. And we're going to learn so much more about that, I think, when HCMR is published in hopefully the next year or so. So just to finish off, cardiac sarcoid, we've talked a lot about cardiac sarcoid this morning. We do quite a lot of MR from the respiratory physicians just to rule out cardiac involvement of patients with sarcoidosis. And sometimes we do see it in quite a patchy distribution. It can take different forms, different areas of the heart, patchy sort of granulomatous disease. I guess what is really important is to know whether it's active inflammation or whether it's old, burnt-out sarcoid. MR struggles to tell you that. There is some work going on about doing edema imaging and other sort of fancy mapping techniques. I think what is nice here is this example where there's been sort of image fusion of the MR and the PET, and you can see now on the PET tracer uptake in these areas of late gadolinium enhancement that there is very active inflammation that you can see that maps really nicely to what we're seeing on the MR. But I think this is one of the really strengths of PET imaging in these infiltrative and inflammatory conditions. Pericardial disease, it's difficult. It's often difficult to look at the pericardial. You often need all of the different modalities in these complex patients to see whether they've got constriction, etc. Again, high-ranking recommendations in addition, in parallel to CT, that often you need advanced cross-sectional imaging more than just transthoracic echo to be able to look for pericardial thickening, pericardial constriction, etc., particularly if you're thinking about surgical planning. Here's a nice, just again, another example, 32-year-old, some chest pain, ECG changes, bit of an elevation in the troponin, normal coronaries. You could argue, is this, so this is a Manoka type picture. And this is what we see on the MR, often completely normal wall motion, but we see this very classic subepicardial hyperenhancement. You can see it all the way down the lateral wall here. This is very classical of myocarditis. It's not an infarct. Infarcts always involve the subendocardial border. You can see the subendocardial sparing. You can see straight away that this is not a missed infarct. This is acute myocarditis in a young patient who doesn't then need dual antiplatelet therapy and lifelong secondary prevention. So important to get the diagnosis right. Finally, aortic disease, again, along with MR, it's something that we do a lot. I sort of disagree with the very top recommendation about thinking about doing MR in patients with an acute aortic syndrome. It's not the sort of place, I think, to have an unstable type A dissection in an MR scanner for sort of 40 minutes or something like that, when you can whip them into the CT department and straight out again and get diagnostic quality images with gated CT. So I don't really ever do that. But again, there are many conditions where you're doing long-term follow-up, particularly of type B patients, where it's sort of healed and settled down. Patients who need lifelong surveillance of aortic root dimensions, Marfan's patients, bicuspid aortic valve disease patients, and things like that. So MR is very good if you're thinking about doing serial assessment, because it's a cross-sectional technique with no ionizing radiation. But it depends whether you use it or have availability to it. If not, CT is just as good. And here's just to show you an array of various sort of images that we can see. The arch, you can see the dissection, you can often see the entry point, you can see whether it's gone down and involved the iliacs, the renal arteries, etc., etc. So very, very useful. And we use it a lot in simple congenital heart disease. I would say simple because coarctation isn't particularly one of the most complex congenital heart diseases that we talk about. But again, coarctation patients have often been repaired young. They still need lifelong surveillance, even if they were repaired as a child. You don't necessarily want to be doing CT scan every year or every two years. Even if they've got stents, we can still image them. Cine images don't work very well, but black blood images can give us an idea of what's going on inside the stent. And so lots and lots of MR done for repaired aortic coarctation disease. But again, CT will give you comparable information. So I think really just to summarize, as I've said, it is the reference standard for many cardiac parameters. There are a few areas of cardiovascular disease where it doesn't have a role, but it usually sort of fits in at the top end, if you like, of the disease severity, where we're thinking about either complex interventions, surgical planning, and things like that. Its major uses in coronary disease, heart failure, cardiomyopathy, adult congenital heart disease, and aortopathy. It is now backed up by an extensive evidence base and in many of the international guidelines. There is wide access to CMR across the UK. I think we've got 80 centres or so in that sort of ballpark out of the 128 acute trusts in the UK that have got a CMR service. So that's most hospitals have access to it. Perhaps we're very lucky in the UK. I think we've got more access to CMR than the whole of the US. In fact, we do more CMR scans in the UK, I think, than the entire US. So we are lucky in that situation. But I think what we're working on very hard is to simplify the image acquisition and accelerate it so it becomes a much quicker, much more user-friendly test, and obviously working through the evidence base with big clinical trials. And I think I'll leave it there because I've just gone slightly over. Thank you. So we won't